I'm Dr. Eric Swanson, and the subject of today's podcast is gender-affirming top surgery. And specifically, this American Society of Plastic Surgeons position statement that was published on February 3rd, 2026. Each page, this was a long statement, it was 9 pages. Each page had a legal disclaimer on it, clarifying that it did not necessarily reflect the standard of care. And this position statement was published only 4 days after a New York jury trial in which a patient was awarded $2 million. She underwent bilateral mastectomies at the age of 16, and the blame was assigned 70% to the psychologist and 30% to the plastic surgeon. In March of this year, there were at least 28 similar lawsuits, and insurance claims between 2017 and 2023 showed that over 5,200 teenage girls have had breast removal for gender transition. So just a month ago, I published a rebuttal of this position statement. One of my most serious objections was that the surgeon's professional judgment was being subordinated to an arbitrary age requirement. For the first time, the board directors of ASPS were carving out a subset of patients whose surgery must be delayed. Traditionally, physicians evaluate patients on an individualized basis. They do a risk-benefit analysis. So no longer can we do that. We have to restrict patients. They cannot have this surgery until they're 19. And in fact, in the US, the minimum age for consent for surgery is 18. And many states impose an 18-year-old age limit for transgender treatment, including surgery. And in January 2025, an executive order banned gender-affirming treatment under the age of 19, so this was raised to 19. And some insurance companies and universities have followed suit. This is an example of a patient. This is a patient of mine, 18 years old, transgender patient, who is requesting removal of breast tissue as part of gender affirmation. And this is done using an areolar incision, an incision that follows the lower border of the areola, so directly removing breast tissue, along with liposuction. This is actually the same sort of treatment that we use in biological male patients who have excessive breast tissue. It's no different. And you can see that in young patients, the skin retracts well. In patients that have small or medium-sized breasts. Here's another patient. This is a 20-year-old transgender patient. You see the patient 4 months later. These patients are very happy with their outcomes. So what do you do with a patient like this who has very large pendulous breasts? Well, you can't just remove breast tissue. You'd have all kinds of extra loose skin to deal with. So we do have to remove skin and extra breast tissue in this situation. Most centers will recommend for such a patient that they have the breasts essentially amputated and the nipples grafted. But in fact, you don't need to do that. You can preserve the nipples on their pedicle. You don't have to graft them. And you can remove the extra skin and do it in such a manner as to place the incisions and the scars inconspicuously so that the aesthetic result is much more favorable. And not only that, the nipples, they're the same nipples. They're not nipple grafts. You can see in this patient, the patient is seen 4 years after the surgery. We then did liposuction to get some more flattening effect. And then you can see the patient 2 years after that. Very balanced look between the chest and the abdomen. And this patient is now comfortable without his shirt on. He never would have been comfortable without his shirt on before. Not only that, he now reported that he had erogenous sensation in his nipples, which he hadn't expected. And when I asked him about his result, he said, "You have no idea." Those were his exact words. So this is how I treat patients that have abundant extra skin and breast tissue. We never graft the nipples. Here's another patient, a little too large, not to remove extra skin. And this is the patient 1 month after that vertical reduction procedure and liposuction. So this patient can come back later. But you can see even now, it's so much better than it was. The patient still has some swelling. This was an out-of-town patient. The patient can come back later for some additional liposuction, which is not a major undertaking. It's not very expensive. There's not a lot of recovery time associated with it. Here's another patient after that procedure where we remove the extra skin but preserve the nipples. And in fact, this patient is on my OR schedule to have liposuction in the next few weeks. Another patient. So nipple grafts The problem with nipple grafts is the nipple is no longer a nipple. It's an inferior aesthetic result, functional loss. They're no longer functional. They're flattened. They lose feeling, no erogenous sensation, and they're frequently hypopigmented. And they may cause chronic pain taking off the nipples because the nerves are still there underlying the chest, and in some patients that's a problem. There are frequent wound healing problems. They're often malpositioned. They're a little too high. Restoring sensation, some surgeons will do this using sophisticated microsurgical techniques, but it's not as successful as just preserving the nipple in the first place, and of course it adds expense. So this is a patient who came and saw, this is not my patient, he had been operated on elsewhere, but he was unhappy. He was still unable to go without a shirt on. He had the traditional double-incision mastectomy procedure with nipple grafts. He had to have the areolas tattooed afterwards because they were too light, but the scars are too conspicuous. The nipples aren't positioned where they should be, no sensation, so an unhappy patient. He would have, if he had to do it over, he would have definitely had nipple preservation, and he may not have even need to have those additional skin incisions. I don't know how much extra breast tissue he had, but there's a good chance that he wouldn't have needed them. So a paper published just in 2024 from a clinic that does a lot of this type of surgery, they advocated totally removing the breasts in some patients and not grafting or preserving the nipples, giving a result like this. There was no preoperative photograph in this paper, so I didn't know how much breast tissue the patient had to start with. But you can also see that the scars are hypertrophic, and that happens. You can get hypertrophy of those long across the chest scars. So a very unaesthetic outcome. We should be able to do much better than this, in 2026. And these patients, some of them had that surgery because it was less expensive, but we shouldn't give patients the option of less expense for no nipples, because it's not that decision is irrevocable. So terminology. You hear about a double incision mastectomy. This term was introduced in 2017. It's a little confusing. Previously, the procedure was called a breast amputation, and the word mastectomy is often omitted. You see this acronym DIFNG, double incision free nipple graft. It doesn't include the word mastectomy. And of course, nipple grafts are always free. There's really no need to say free. Some surgeons call this chest reconstruction, but it's really not reconstructive at all. I did an outcome study looking at my patients that had this treatment where 100% had nipple preservation, just to find out what kind of results they had. So patients filled out surveys. All of my patients undergoing this surgery reported that nipple sensation was important. And there were no complications of the nipple areola complexes. None of the patients were comfortable without a shirt before surgery, but all were comfortable without a shirt after surgery. And that's really the bottom line consideration. And patients reported a major improvement in self-esteem. Now, reversibility is a very important topic, and it's often overlooked. We have to remember this isn't cancer surgery. We don't need to be removing all of the breast tissue. And mastectomies and nipple grafts are not a reversible procedure. We also need to remember that the male chest is not completely flat. There is some volume to the male chest, and overcorrection can produce disharmony if you remove all the breast tissue. Here's a patient. I have not, in fact, had a top surgery patient come back later with regret and say that they wish to undo the effect of the procedure. But I have had a gynecomastia patient, and you can see him here. This is a male patient that had excess breast tissue removed, and then years later came back requesting breast implants. And he said he had some gender issues and was gender fluid, so we actually put in implants to give him a more female appearance to his breasts. So you can reverse the effect of this procedure. Now, is nipple sensation important? Well, it turns out it is. In women, erogenous nipple sensation is important in 81.5%. And MRI studies show that the impulses travel to the same area of the brain as genital stimulation. And here's the perhaps surprising thing. It's also important in just over half of cisgender males. But regardless of sexual function, sensate body parts are always preferred. When we go to the dentist, we would never want that numb sensation in our chin to be permanent. So is there a role for nipple grafting? No, there isn't. Not in aesthetic breast surgery. I don't perform nipple grafting in breast reduction, gynecomastia surgery, or gender-affirming top surgery. So when you compare the two techniques, that mastectomy technique compared to the nipple preserving technique, just about all the advantages are with nipple preservation. The only disadvantage is you may not get the breast as flat as you'd like, and you may need to come back for a liposuction procedure to get that. But keep in mind that even with the other procedure with mastectomies, there are often secondary procedures to take care of scar deformities or nipple areola deformities. So having a second operation is not a deal breaker for most patients, and they're told that up front. And in fact, some never come back to have that second procedure. So another problem with that position statement is a disparity in treatment recommendations, because gynecomastia patients, those are biologically male patients, they're rarely offered mastectomies, whereas gender-affirming top surgery patients, most of them they're recommended mastectomies. Why is that? It's basically the same, very similar condition, very similar procedures available. So breast reduction is available to teenage cisgender girls, but with this new rule, not transgender patients. Both conditions have major physical and psychological components. We have to remember the cisgender male teenagers can have gynecomastia surgery, but with this new rule, the trans patients cannot. So is it compassionate to make a transgender patient who's binding his chest to wait until the age of 19 to have the surgery? So there are a number of problems with the ASPS position statement that I've alluded to. My objectives when I treat these patients is preservation of the nipple areola complex. That's something that is not negotiable. Minimize scarring, and of course, reduce the breast volume. Thank you.